Hello, welcome to another episode of ICU Doc Talk. This is a podcast where I talk about a medical topic, and I usually follow it up with some book reviews about history or politics or other stuff like that. I am a medical doctor. I am double boarded in anesthesiology and intensive care. I'm also an ECMO practitioner, and I work in a cardiac surgical ICU. Today we are going to talk about pulmonary hypertension. And then I'll get to some emails. And then I'll talk about some books. The books today one is called Psychopolitics, Neoliberalism and New Technology of Power by Hahn. And then I'm going to do Ubik by Phillip K Dick. And also another book called Lancelot by Giles Kristian. All right, there's the agenda. Let's do it. Okay, so my discussion today about pulmonary hypertension is coming from an intensivist anesthesiologist. Okay, I'm not a cardiologist, and what I mean is this is not going to be a nuanced, granular discussion about all the different nuances of pulmonary hypertension. Rather, I'm going to be discussing the management of frank pulmonary hypertension, like the critical care anesthesia management of pulmonary hypertension. Okay, just to kind of set your expectations. Because pulmonary hypertension is a huge topic. And it's very complex, and I don't claim to understand everything about pulmonary hypertension. But I do manage it a lot, right? There's a big difference between understanding, being an expert in a disease like pulmonary hypertension, and managing someone with pulmonary hypertension. There is a big difference, right? I manage people with pulmonary hypertension, but I'm not a cardiologist expert, right? That would be a cardiologist, would be an expert in pulmonary hypertension. And I'm discussing pulmonary hypertension in the acute setting, not the outpatient setting, right? Very, very, very different worlds. I almost never talk about outpatient stuff because I'm an inpatient doctor. Okay, so acute pulmonary hypertension and illness. So that I do have a lot of experience with, people that are very sick from pulmonary hypertension. So what is pulmonary hypertension? Hypertension means high blood pressure, right? And usually in medicine we talk about hypertension, just regular old hypertension. That is your systemic arteries. Okay, so just backing up to a little bit basic anatomy. You have your aorta, which comes off the heart. That's your main highway muscular artery that comes off the heart, and it feeds all of your body. When the blood pressure is high, that's hypertension, systemic hypertension, right? And that's bad. Chronic blood pressure, high blood pressure, hypertension is bad for your body. It's bad for end organ perfusion. It can put you at risk for strokes and kidney disease and heart disease, lots of other stuff. You should not have uncontrolled blood pressure. Okay, just your friendly reminder. If you have high blood pressure, you need to get it controlled, or you will likely die early. Okay, we're just going to remind you about that. Pulmonary hypertension is in the name, right? This is the vasculature that goes to the lungs when it has high blood pressure. Okay, and just because you have normal high blood pressure doesn't mean you have pulmonary hypertension, right? These are I want you to separate these things in your mind. If you're, particularly non-medical, these are very different things. Very, very, very different things. Okay, so what is pulmonary hypertension? Well, you should always think of the heart as, you have four chambers, and you have two different hearts that are, you have your right ventricle. So you have your left ventricle that's what's squeezing through your aorta to the rest of your body. Systemic blood pressure, okay? Your right ventricle, it squeezes through what? The pulmonary artery. And the pulmonary artery bifurcates, it branches off into the left and right pulmonary arteries. And that blood flow goes to the lungs. Okay. What does it do at the lungs? Does it feed the lungs blood supply? Maybe a little bit, but the other other arteries do that as well. It does feed, some tissue, of course, but the main job of that is to perform gas exchange. Right? You offload your carbon dioxide and you pick up oxygen, and it goes through a capillary bed. Right? The arteries get very, very small arterioles. They go to a capillary bed, and then they turn into pulmonary veins, and those pulmonary veins return to the left atrium. Then they go to the left ventricle. Now they're nicely oxygenated to go back out to the body. Right? Okay. So basic anatomy. Pulmonary hypertension is where the pulmonary artery or the pulmonary vasculature means blood vessels, the blood pressure is too high. Okay. Why is that a problem? It's a big problem in many different ways. Okay. Your right ventricle is not as muscular as your left ventricle. Your left ventricle is the meaty, muscular part of your heart. Why? Because it's pumping. It's the doing the job to perfuse the rest of your body. The right ventricle doesn't need to be muscular, because it's just pumping to the lungs. So it's a low pressure system. Well, it should be, right? The right ventricle is thin, right? It's very pliable. It's a thin muscle wall compared to the left ventricle. All right. So the reason that's the problem is what is the right ventricle doing? It's pushing against so it's during systole, the right ventricle is contracting. And what is it doing? It's pushing blood out through the pulmonic valve into the pulmonary veins, pulmonary artery, while the tricuspid valve closes, so you don't backflow back into the right atrium. Okay, so it is squeezing blood, and it's pressurizing, and it's opening that pulmonic valve, and it's going to the pulmonary artery. Okay, the pulmonary artery pressures are generally quite low. Okay, so let's review pressures of your chambers. Your right atrium generally is the lowest pressure, around 5 millimeters of mercury. Okay, and then your left atrium, maybe around 10. Your right ventricle, around 20, 25 during systole. And then your left ventricle, now the pressures are high because, again, it's pumping your body, 100 plus millimeters of mercury. Okay, so right ventricle, low pressure system, not as muscular. So the normal pulmonary, pulmonary blood pressure is just like systemic blood pressure. So it's measured that same way. There's a systole and a diastole. So normal blood pressure is like 120/80, right? Normal pulmonic blood pressure is like 20/5, 15/5, right? With mean pressures of 10. That's pretty normal, okay? Okay, so the problem with pulmonary hypertension is those pulmonary pressure goes high. Maybe they're 30/20. Maybe they're 50/30. Maybe they're 70/30. Maybe they're 80/50. That is high. They start approaching systemic blood pressure. That's a problem. Why? The right ventricle can't handle it. Okay? Because as I said, it's not as muscular. So now it starts really working. Okay? And it starts to enlarge. And now you have a dilated pulmonary or RV. RV stands for right ventricle. And it's highly pressurized. And then, now it's too pressurized. And now you have tricuspid regurgitation because you're changing the tricuspid valve, the geometric conformity of that, because it gets all spread open. And now you get backflow, and now you're getting a tricuspid regurgitation, likely. And then your RV, so it may stick with that for a bit, right? And there's a difference between RV enlargement, distension, and RV failure. So the RV can keep up, but it can't go on forever, and then it can start to fail, and then you go into RV failure. Now, your RV and your LV are coupled together, right? Your LV gets all of its blood flow from the pulmonary veins, right? Almost all its blood flow. There's the Thebesian veins, right, that drain directly into the heart. But almost all that blood flow comes through the left atrium and into the LV. So it impacts the rest of your body. You need flow, right? If you have too much flow, too high of pulmonary vascular resistance, or PVR, that's too high. Your RV, you have worsening forward flow through your RV, and it can't keep up, and you go to RV failure. And then you stop. And then you start underfilling your LV, and now you have mismatching of these pressure, the pressure in these chambers as they should be, and now you have low blood pressure, and now you have shock, now you have cardiogenic shock. And then you have this downward spiral, which gets worse and worse. Now you stop perfusing your body very well. You go into cardiogenic shock. Your SVR, your systemic vascular resistance goes up. You go into end-organ failure. Your lactate goes up because you're going into anaerobic metabolism. And you can die. It's very deadly. Okay. Now, what are the causes of pulmonary hypertension? Well, there's many. And again, I don't know all the granularity of all the different causes very well. But you generally want to ask yourself, is it the language we use when someone has pulmonary hypertension? You ask, is it pre-capillary or is it post-capillary? And what we mean by that, we mean pre-pulmonary capillary bed or post-pulmonary capillary bed. What we're meaning is this primary idiopathic, like pulmonary hypertension, like the pulmonary vasculature itself is diseased? It's like fibrotic, It has interstitial, like, what's the word? Like, a connective tissue disorder, that the pulmonary vasculature itself is just idiopathically pathological, it's not working. Or do you have really bad, so that would be pre-capillary bed, right? Or is it post-capillary, meaning maybe this person has really bad mitral stenosis, meaning on the left side of the heart, and now they have a hugely pressurized left atrium, and all that blood is backing up into the pulmonary vasculature, and it's causing pulmonary hypertension, and their RV is going to failure because of that, right? And their LV is underfilled, and they're in shock. It's very important to identify the reason someone has high pulmonary pressures. Maybe they have high pulmonary pressures because they have a massive pulmonary embolism, and their RV pressures are really high. Okay, so it's very important. Diagnosis is very important. Some people just have pulmonary hypertension, and as I said, it's idiopathic. You don't know the reason that they have it, and it can be managed as an outpatient as well with cardiac confusions like dobutamine or milrinone. But I'm not going to get into that. Okay, so setting the groundwork. That's pulmonary hypertension. It's very dangerous. In fact, it's so dangerous. Let's say now it happens to me every now and then that I find myself in a patient's room that I don't know this patient. I was just called into the room from somewhere. I don't know anything about the situation, and I need to intubate the patient. That happens. And let's say I don't have time to even look up the chart, and I don't know anything about the patient. You know what? I ask. I before I give induction meds, if I have limited time, I say, does this patient have pulmonary hypertension? I really want to know that. So as an anesthesiologist, I really want to know if someone has pulmonary hypertension, because I can kill them with my induction medications. Okay, because induction medications, what I mean by that is like propofol. I mostly mean propofol, but there's other induction medications. Because what happens is, in someone with pulmonary hypertension and kind of RV overload, we call it preload dependency, where their forward flow is now dependent on a higher venous tone and constriction, venous constriction. And if I take away their preload by giving them a bolus of propofol, now I take away all of their forward flow, their preload dependency, although that's a controversial concept. And they no longer have any forward flow through their pulmonary vasculature, and they go into cardiac shock, and they can die. They can go into cardiac arrest. Very, very, very dangerous. Okay. Okay. So I think to delve more into this, I'm going to talk about two different cases of pulmonary hypertension and how they were managed. These are very, very advanced, sick pulmonary hypertensive case. The first one I'm going to talk about is a postoperative patient. And I'm not just talking about any one single patient. I'm going to talk about a type of surgery that often results in this type of physiology. Okay. The first one it's a pulmonary thromboembolectomy. Pulmonary thromboembolectomy, where a surgeon goes in. So chronic pulmonary thromboembolism is the disease that can cause high pulmonary hypertension. So these patients have they have pulmonary hypertension from chronic pulmonary thromboembolism. We often, the acronym for this we use is CTEPH, chronic embolic pulmonary hypertension. Okay. And these people have very, very progressive right heart failure, and they can die from it. Absolutely. So a cardiac surgeon will go in and do a what I mentioned before, a PTE, a pulmonary thromboembolectomy. Ectomy means to take out. So they go in and they take out these clots. Now, they're not just taking out clots, they're taking out the intimal layer of their pulmonary vasculature. Okay? And that's an important distinction to make, because if you go in and you tear out a bunch of clot and a bunch of tissue, intimal layer of their arteries, you create tons of inflammation, right? It's a huge insult to that patient's lungs and the patient's vasculature. All right. So a surgeon goes in there and relieves him of this burden, and it's these are long, complicated surgeries. All right. And now you have a patient post-op. So I'm going to talk about a post-op patient. Looks like this. They have high pulmonary pressures, right? 50/30, 60/30, 70/50, maybe even 80/40. I've seen 100/60. I've seen 120/80, right? I've seen suprasystemic pulmonary pressures. That's a problem. If someone has suprasystemic pulmonary pressures, they're not really having any forward flow through their LV, right? into the rest of their body. That's someone who's like dying and needs lots of help. Okay, so you get these patients, and they have that clot burden taken out. And these are extremely complicated patients to take care of. They're very complex, and they're very difficult to take care of post-operatively. So one of the main challenges with these types of patients is they now have a huge insult to the lungs, and they have a bunch of inflammation going on. Their pulmonary hypertension is still there. It doesn't immediately go away, okay? And they have a failing RV. Like, they walked into the hospital with a failing RV, with like severely reduced systolic function of their RV, RVSP or PASPs, super high, okay? And now their pulmonary pressures actually might get worse. So what you need to balance, and so they can go to RV failure. But here's the thing: what you need to balance is they can get reperfusion injury of their lungs. What that means is that thromboembolism is gone, and now they have flow to their pulmonary vasculature, and that getting flow can cause reperfusion injury. Right? This happens when you have damaged tissue, and blood flow is restored to an area that was ischemic before, and it happens. This new blood flow triggers cytokine release and activation of the inflammatory process. So they can now go into hypoxemic respiratory failure, right? They can get like ARDS, and they often do. This is a very high-risk patient. So what do you do to treat pulmonary hypertension? Let's talk about pharmacology. I'm going to come back to this patient case. What are the basic things you reach for in an acute setting? You want something that is inotropic, meaning it helps contraction of your ventricles, but you don't want to increase your PVR, your pulmonary vascular resistance. Okay, so things that don't increase pulmonary vascular. So norepinephrine and epinephrine, certainly you can use them in these cases, right? But they increase your PVR as well. But the general approach is you want to have inodilation. You want to have inotropy and pulmonary artery dilation. And there's specific medications that do that. Milrinone, which is a phosphodiesterase inhibitor, does that. That's its mechanism of action. And dobutamine does that as well, which is a beta agonist. That increases contractility and it dilates the pulmonary vasculature. So that's kind of your ideal, okay? And then there's other inhaled therapies, also IV therapies, that are pulmonary vasodilators, like inhaled nitric oxide, right? That's a pretty potent inhaled vasodilator. Epoprostenol, alprostadil, these are different therapies. No, I don't think one is superior to the other, but they dilate the pulmonary vasculature. Okay, so that the whole aim of this is to dilate that and increase inotropy, increase your flow, drop your PVR, increase your RV contractility. Right, that's like the mainstay of treating someone with pulmonary hypertension. The problem with this patient case I'm talking about, this pulmonary embolectomy, is that if you increase flow through PVR, you drop your PVR, you increase flow, you're increasing the reperfusion injury, you're causing ARDS, you're becoming hypoxic, you're becoming hypercarbic. That's bad on your RV as well. You go more into RV failure. And there's also thought that increasing inotropy can also increase reperfusion injury. I don't know if that's true. I don't know if there's a lot of data behind that. But in our practice, we try to avoid inotropy as much as possible and pulmonary vasodilators as much as possible. That is a really hard thing to do in a patient who has chronic pulmonary hypertension and RV failure. It's very difficult. So you try to limp them along with forward flow by avoiding inotropy as much as possible, and maybe supporting some norepi and vasopressin. So vasopressin is a unique drug in that it doesn't squeeze so much on the pulmonary vasculature as much as norepi or epinephrine. So you can increase your SVR, your systemic vascular resistance, without increasing your PVR. So that's like standard, starting vasopressin in these patients for sure. So when you have a patient like this scenario that I'm talking about, they've had a pulmonary thromboembolectomy, and now they have increased flow to the pulmonary vasculature. They have inflammation. They have, and their RV is failing. Now you're having real issues, and you try to avoid pulmonary dilators, but there's a certain point where you just can't anymore because their RV is going to fail. And so you start them on, inhaled nitric oxide or EPO or alprostadil or whatever is like the easily available in your institution I don't know. There's not a big difference in the acute management, in my opinion, of what kind of pulmonary, vasodilator that you're going to use. But you start those things, and then they get more reperfusion injury, and then they're now hypoxemic. You have them on 100% FiO2. You can't control that anymore. And now maybe they're going into RV failure as well. And now their lactate's rising because they're not perfusing. So they have to go on ECMO. And this happens with this type of patient population. Usually, sometimes they just go on VV ECMO, venovenous ECMO, but a lot of times they have to go on VA because they're also in right heart failure as well. And then you have them on ECMO for a long time, and I've seen these patients not do well. I've seen them do well. I see them do okay, but also not. Another kind of situation with pulmonary hypertension. So let's just talk about. So I'll talk about a case I had recently. A patient with idiopathic pulmonary hypertension, recently diagnosed, and talk about a different kind of management with this patient. So this patient was, relatively young, and didn't have too many comorbidities, and just, sometimes they come in and they're like, oh, I just wasn't feeling right. They weren't getting around as often as well as they could, a little more fatigue and things like that. And then someone gets an echo and their RV is completely ballooned out. They have severely reduced systolic function. Their TAPSE, their tricuspid annular plane systolic excursion, is super low. And they're in right heart failure, and their pulmonary pressures are through the roof when they get a heart cath. When those pressures are measured, which is really how you diagnose this. So the patient had a PA. You place a SWAN or a PA line in these patients so you can monitor their CVP and their PA pressures. And this patient appropriately had a lot of these pharmacological management that I was talking about, right? With epinephrine and a little norepinephrine and inhaled nitric oxide and EPO. So this patient was on quite a lot of support. His pulmonary pressures were, 100/60, right? And that was his systemic pressures as well. So he had near suprasystemic, at times, pulmonary pressures. And that is a dangerous situation because you don't have forward flow, right? If you can't pump through your pulmonary vasculature, then you no longer pump through your left ventricle. And so the patient was very high risk of dying, sudden cardiac arrest. Was in sinus tachycardia, doing okay, and I was involved because I do ECMO, right? So this was a patient in our cardiac ICU, not our cardiosurgical ICU, but our cardiomedical ICU, right? There's a difference between these two, and they are quite different patient populations. So I got involved. Hey, is this patient? Should we put this patient on ECMO? Would they benefit? What if they crash? And the patient was awake and on BiPAP, 100% FiO2, right? Getting 100% oxygen on positive pressure ventilation, but it was BiPAP. So, however, this patient's lactate was normal and making tons of urine and overall net negative fluid balance. So the patient, although very sick, no urgent need, no need at all to put the patient on mechanical support like ECMO. Why? Because the patient was already well supported on pharmacologically. Now, if the patient came and the patient had a couple other comorbidities that were relative contraindications for ECMO that I won't get too specific about, but it made it so it was a difficult choice. It made it so it was like, maybe this patient's not a candidate. And we made this decision with several people and a surgeon. Lots of people were involved in this decision making, so it wasn't just me, as it shouldn't be. It shouldn't be. In a case like this where you have time to think about things, you should get as many people involved. Although sometimes you get into the situation where you have too many opinions, too many theoreticals, too many thought models, and that it starts to become counterproductive, and you perseverate, and you don't get anywhere. I see that situation happen often. Anyway, what was I saying? So the patient didn't have current ECMO needs. That was clear, and a couple of relative contraindications as well to ECMO. So we didn't place the patient on ECMO. But then the patient started to do worse from a respiratory standpoint and started to get bilateral infiltrates and opacification, likely related to maybe it was from EPO and reperfusion injury, or it was unclear. Didn't have a PE, pulmonary embolism. So the thought was, well, we need to intubate this patient. Okay, So that's kind of what my main teaching about talking to those cases is approaching intubation with a patient like this. So I think I already talked about it. So if you induce medication and you drop their preload, they're at very high risk for cardiac death, sudden cardiac collapse. I've seen it happen. You induce them, you put in a tube, and they go immediately into cardiac arrest, and you try to resuscitate them, and you can't, and they die. I've seen it happen before my eyes. So this patient was certainly at risk for that happening. So we formulated a plan that we were going to intubate the patient, and if they crashed with induction, meaning they arrested, then we would immediately cannulate the patient onto VA ECMO, venous arterial ECMO. Okay. And we had a little bit of time because he wasn't like really crashing hard. It was kind of a smoldering, like, patient's not doing well. So we had like an hour or two to get all of our ducks in a row. So the planning we did this. So I put in when you have time advance to when you know someone may need ECMO, you should put in catheters in their femoral groin, in their femoral vessels beforehand that you will then use later to put someone on ECMO. So I placed a 5 French catheter in the femoral artery, common femoral artery, and another one in the common femoral vein on either side. You could do it on the same side. I looked at the vessels beforehand, and I placed those in the ultrasound guidance with the patient awake with some local, lidocaine infiltration. The patient could not get any sedation. Because even a little benzo can drop their sympathetic tone a little bit, and it can kill them. They're really, really on the razor's edge. So that was fine. So I put those in, and so then we approached induction, right? Now I've intubated a patient like this many times, and I think there's 2 ways of doing it. You either induce them with a little benzo, and then rocuronium, a paralytic, and so you give them like a couple of Midaz or remimazolam, which is a newer benzo, and then you give them a full paralytic, and you tell them you may be aware as I put a breathing tube in, so you apologize in advance, but say it is very necessary because I don't want to give you too much sedation because I think it'll kill you. And I've done it that way and intubated them and have the patient survive just fine. I've also had them not survive. And then the other way of doing it is doing an awake fiber optic intubation. The benefit of doing an awake fiber optic intubation is that you go from BiPAP right to the same, and you put them on the same settings as the, once you have a breathing tube in, you don't give them any sedation at all. And so you don't drop their preload or anything. So that's the benefit there. Now, it kind of depends. Doing an awake fiber optic on these patients sometimes can be very difficult. So the way you do an awake fiber optic is you topicalize their airway with local anesthetic. You can do that many ways, but usually I do a nebulized lidocaine, and then I atomize the back of the throat with lidocaine. You can do a couple of other things to get that topicalization. But a lot of times they have copious secretions. It doesn't penetrate very well. And then you try to do the awake fiber optic with them awake, and they can't tolerate it, and they're gagging and coughing, and then you eventually just induce them and paralyze them and get them off to sleep anyway. Anyway, for this particular patient, we put a sleep endoscopy mask over their mouth, had them on BiPAP. That has a seal over the hole. Through that hole, I introduced an endotracheal tube into the mouth, and then I put a fiber optic camera through that. I topicalized with nebulized lidocaine 4%. I sprayed a little bit more in the back of the throat. I then advanced the the bronchoscope over the tongue, back of the tongue, into the vocal cord, sprayed a couple more times through the scope with lidocaine, numbed it up. Patient was wide awake. It did amazingly well. And then I passed the bronchoscope through the vocal cords down into the trachea, and then I railroaded the already loaded endotracheal tube down that. Took everything out, left the endotracheal tube in place, and then the patient kept breathing on their own. No sedation. He was like tough as nails. And patient survived that. Okay, didn't go into cardiac collapse or anything. And that went fine. So that's kind of how you do manage that. That's how, just to give you an example of how bad pulmonary hypertension, how dangerous pulmonary hypertension is that you need to go to those extremes. So I did not have to put the patient on ECMO. They survived that. Now, about 10 minutes later, the oxygen saturation went down to 80%, and their pulmonary pressures did become super systemic. And we kind of hemmed and hawed about putting the patient on ECMO. We didn't know if the sats were low because this was a primary hypoxemic driver, or it was because the patient was having intracardiac shunting because there wasn't enough forward flow into the LV. And maybe there was a PFO that had opened up, right? There's always, you just don't know. And another teaching point of this is we perseverated at the patient's door while she was satting 83%. She was awake, so we didn't have to act right at that moment. But I was like, why don't we walk away for a few minutes, and stop focusing so much, stop perseverating, and just and see how the patient does, and then we'll come back. 10, 15 minutes. And obviously, if we need to come back sooner, we would, right? It's not like obviously the patient's getting care with nursing care. No one's leaving the patient alone. So we did that, walked away, came back to the patient, and, played with the PEEP a little bit, went up on the PEEP, down on the PEEP, kind of a diagnostic to see, hey, is the PEEP increasing the preload too much? Or, and that the RV can't keep up, or does the patient need more lung recruitment with higher PEEP? So that played with, and we found a good spot. The patient sats came up back into the 90s about 15 minutes later. Did not have to go on ECMO, but easily could have. So anyway, I hope that was helpful discussion about pulmonary hypertension. Just the takeaways are, if someone has pulmonary hypertension, you want to know how bad it is, right? If they have mean pulmonary pressures of like 30, that's not that bad, right? That's not that bad. If they have mean pressures of 70 or 80, if they have PSAPs or RVSPs, 50, 60, 70, 80, that's bad, right? You need to pause, and particularly if you were in critical care or anesthesia or you work in the emergency department, you need to think about your sedation that you're going to give them. You need to think about that, how positive pressure can impact their preload negatively as well. You need to be very thoughtful about these things. If you induce them, you need to have an inotrope in hand. Start an epinephrine infusion, or have epinephrine available to bolus at 10 mics at a time. If I induce these patients, I give them epinephrine in advance with their induction medication. So I forgot to mention that. So I give them a little benzo, some rocuronium, and like 20 mics of epinephrine. I start a drip before I even put in a breathing tube. Now, it's simple, but if you don't do these things, you can kill a patient. So you need to be thoughtful. You need to do things correctly in a thoughtful way and slow things down and think about it. Very, very dangerous situation. All right, let's move on to some emails. Lots of emails. I definitely can't read them all. But just so many great emails. This was from Dan. Dan says, I've only listened to a few so far, but I enjoyed the What Even Is Blood Pressure episode a lot. It's filling in a lot of gaps in my informal education. Please keep at it and ignore the trolls, haters, and losers. If there is a way to support you, let me know. I believe in paying for SMEs whenever possible. Thanks, Dan. I appreciate it. Thank you for that email. That's why I love to do it. And you don't need to pay me. I don't plan to monetize the podcast, but I do appreciate the sentiment. All right, here's another email from Jared, last name withheld. It says, hi, I've been an Instagram follower for a while. Loved your post. I was very disappointed when you decided to stop making them, but I understand. I nearly got off social media altogether due to the rampant toxicity of those platforms. You mentioned podcasts, and I finally got around to starting them yesterday. Yes, I may make it all the way to the end. They are phenomenal. The fact that you're able to do more long-form discussions gives the topics you address the respect they deserve, more than I think is possible with shorter social media posts. I worked as a phlebotomist at a level 2 trauma center for 16 years and all through school. I worked nights, so I was everywhere: med-surg, intensive medical, intensive surgical, PICU, NICU, trauma, etc. I initially planned to go to med school as I wanted to go into emergency medicine. I was accepted to a school in New York, but as a single parent with 2 daughters, I would have had to leave them behind for school, as I realized there was no way I would be able to move there for med school and continue to parent the way I felt was necessary. I decided to go to a chiropractic school, as the school was 20 minutes away from my home, and I could still fulfill my goal of helping people out of their pain. I'm happy with the choice I made, but I miss being in the hospital. I miss being on the floors. I miss getting to see the more complex cases as they develop, asking questions, looking up additional research, and just learning in that environment. Listening to your podcast and the medical topics you discuss almost seems to fill that void. I've also started making a book list, as many of the political topics you discuss seem to align with my thoughts and feelings, and I would love to do more to be more knowledgeable on those topics. Anyway, there's much I could go on about, but I figured I could at least give you that feedback. Love the podcast. Can't wait to listen to more. Thank you, Jared. Jared, what a great email. Thank you so much. Thanks for sharing your amazing story of, as a parent, I would, yeah. I just think that's amazing for Jared to make the right choice, to be the parent that he wanted to be, and put that above his career choices, which honestly, for me, is, I know it can sound so contrived and trite, but your family, whatever your family is, whether it's children or not or whatever, is so much more important than your career. It just is. Now, that's easy for me to say as a gainfully employed U.S. physician, so take that for a grain of salt. But putting your family above your career is so important. For me, my own personal career choice, I work at a major academic center, but I have very couple rules I follow in my life, and one of them is I never bring work home. I never work at home, ever. I don't work on papers. I don't do Zoom meetings. I don't look at patient charts, ever at home. And I really don't. I really do not do that. And I don't take any leadership roles, and I'm not on any committees. I don't try to develop anything like that. It's just too much. I already do so much, right? Whatever your job is, you already do so much. You really should not take on more than if it interferes with your family life, and interferes with particularly being a parent. I just strongly believe in that, and I think that's awesome that Jared made that choice. So thanks for that email. Beautiful. Another email from Brendan, last name withheld. I wanted to ask your thoughts on some recent news regarding Anthem, Blue Cross Blue Shield. From my understanding, it seems that their plans will no longer cover anesthesia during surgeries in certain states. If the anesthesia exceeds a predetermined time limit they've set for the procedure, my initial reaction to this was this policy could create pressure that conflicts with providing safe and effective care. As an anesthesiologist, I'd love to hear about your perspective. How might such a policy impact clinical practice, patient safety, and the broader healthcare system? Are there any ways you see this being navigated effectively? P.S. I just finished listening to every single podcast you have. Wow, awesome. So yeah, I'm glad I read this. Thanks for the email, and I probably should have made an episode about this and the other current stuff. But so yeah, this is obviously a stupid, boneheaded idea to put limits on anesthesia time. Yeah, to not have reimbursement for anesthesia time. Let me tell you how this would negatively affect patient care. Oh, and I should mention they rescinded that, right? This email is a little old. The Anthem, Blue Cross Blue Shield said they wouldn't do that. They rescinded this, but it's a huge red flag that they even brought it up. So one of the things, just American medicine already has so many problems, right? It's way too corporatized and it's profit seeking, all that stuff, right? It's already designed like an assembly belt line to just produce. So that's what this would do even more so, right? So if surgeons, so this would impact your surgeon's time, right? If your surgeon knows that they only have an anesthesiologist for a certain amount of time, they're gonna operate too quickly, or they'll be incentivized to do more and more surgeries to make up for lost revenue as well. An anesthesia group could potentially do that. Just having more work and more rushed operations, more surgery. That's a potential impact of doing this. Another one is just your case. Say you need a laparoscopic cholecystectomy, right? You need your gallbladder removed. But let's say you have complex medical history. Well, maybe that operation is going to take a little bit longer because of that reason. And then a bureaucratic insurance company doesn't understand this nuance. So they're going to be like, well, we won't reimburse because, hey, they're going to have all their data, right? And be like, hey, it should only take X amount of time. And so what will happen is a surgeon or an anesthesia group will be like, well, we just won't do your surgery. Go somewhere else because you're too medically complicated, right? So this bias against more sick and medically complicated patients. That's another thing. That's another potential benefit, or not benefit, disadvantage that could happen, is you just won't be accepted to even have surgery to begin with because you're too medically complex. That could happen. Now, those things could happen. One thing that would almost certainly happen if it were to come to place is surgeries are unpredictable, right? And if they go along for whatever reason, things can happen and they go a little bit longer, right? Now, No anesthesiologist or surgeon is going to just stop and go be like, oh, that's all I get paid for, right? See ya. We got to turn this off. Wake up, right? That's not going to happen, right? For one thing, it's highly unethical and stupid. That wouldn't happen. What would happen is the surgery would keep happening. It would go beyond the allotted time that the insurance said they'll reimburse, and they'll keep going, and then the patient will pay the rest of that bill, and that would be a tremendous amount of cost, right? And then it would bankrupt people. That's what would happen. I think that would be one of the biggest impacts. Is the patient would just pay the rest of the bill that the insurance deemed was not necessary to cover, right? All of this just is another symptom of the pathological corporatization of medicine in the U.S. healthcare system. It is a nightmare. It's a disaster. It's a human tragedy, and this is just another big sign of it, right? We live in a kleptocratic corporatocracy, right? That is the nature of our fabric of our society, and it's kind of always been this way. To be honest, it really has. It's only gotten worse, and it'll only get worse. It really will. So anyway, I wanted to talk about briefly. This just also reminded me the shooting of the United Health, the assassination of the United Health CEO. I forget his name. I don't have any, and the killer's name. What was his name? Luigi Montione or something. I don't have much to say about it. This is all I'll say. I think is that the fact that we live in a society where both that CEO makes such obscene wealth from increasing short-term profits of his shareholders of the company, and he does that by cutting costs everywhere, and he does that by denying people's health insurance, and that very, very likely results in them having chronic disease and morbidities and early death. Undoubtedly that happens. So the fact that we live in a society where that happens, and then the fact we live in a society where that person is then assassinated in cold blood in the street, and a large part of this country's response is mob mentality, where they're actually cheering that on and celebrating the murdering of someone in the street, just shows you how degenerate our society is. We are very degenerate. These are just huge signs of all the symptoms. When I hear someone cheering that on, or being like, "Oh, I don't have sympathy for the CEO," when I hear that, here's what I hear. I approve of one person being judge, jury, and executioner. I applaud that, and I want more of it. That's what you're saying. And I fundamentally disagree with that. That's just all there is to it. And the fact that all I could think of this is that of the waste and tragedy of two lives lost between the man that was killed and the man that will be imprisoned for, the young man, 26-year-old that will be imprisoned for, his whole life. The loss of those two lives is tragic. That's all I have to say. All right, let's move to book reviews. First book I'm going to talk about is called Psychopolitics, Neoliberalism, and New Technologies of Power. This is by, I'm going to mispronounce the name, Byung-Chul Han. I'll just spell it. Byung-Chul, and then last name is Han, H-A-N. This book was written it's a short book. It was written in 2014. I have an axe to grind about this book, and it's probably going to get annoying to you. But first, let me talk about the good of this book. So, the concept of a neoliberal panopticon, a panopticon, if you're not familiar, is a concept of a prison design where you have a prison, an actual, like the architecture of a prison, you have it in like a circle, and you have the cells in a circle around a main hub, and there's one guard that's watching from that main hub that can watch the prisoners. Now, and the guard can see any prisoner that he or she wants to at any time, but the prisoner doesn't know when they're being watched. So you could actually a guard could just leave, and the prisoners have no idea, but they just know it's basically surveillance. There's this constant threat of surveillance all the time. That's the concept of panopticon. So there's this concept of a neoliberal panopticon, right? Whether that's capitalistic surveillance or government surveillance or whatever. So this concept of neoliberal panopticon, in which, in contrast with the coercive systems like described in 1984, right? Neoliberal panopticon is we willingly participate in capitalistic surveillance, which is one of the things this book talks about, I think is kind of obvious. Neoliberalism, right? Which is just, neoliberalism is basically supply side economics, get rid of taxes, expand privatization, get rid of nationalization, get rid of the welfare state. That's neoliberalism, if you're not familiar. Neoliberalism is better described by the decadence of a book like The Brave New World. Neoliberalism today. This point, which the author makes over and over again, is really banal at this point. Maybe it's just because I read so much in this vein, especially when you read often like this. The author explores Foucault's concept of biopolitics, in which governments attempt to control the bodies of people. And the author argues that this has transformed into psychopolitics, right? This book is called Psychopolitics, in which we are ensnared in a prison of our own minds more than the body, wherein our data is used to predict and mold our behaviors. To this point, the author says something like, the smartphone has become the new torture chamber, right? Which is an utter false equivalency. Aside from comparing bodily torture to a smartphone capital surveillance, I kind of want to explore a little bit more about why this book kind of bothered me. This author obscures much of what he says behind jargon and ambiguity, which is deliberate. And what I mean is there are many concepts in this work that are kind of weird and they're too generalizable. Like he talks about data sex stuff, which I barely understood. He talks about a dictatorship of emotions, right? He comes up with terms. And unless perhaps you're initiated into like Hegelian school of thought, which is the underpinning of this entire book, you don't quite understand what he's talking about all the time. And the problem with the mentality of books like this is that you are, and this is a Marxist writer, obviously, the problem with the mentality of books is this, that you're either an acolyte of what they're saying or you're a Western propagandist. And there's no in between, and there's no room for dissent with books like this. The author hides much of what he says behind jargon. And if you call it out, then you just don't understand the text, right? That's always the response you get from Marxist writers or Marxists. And I run into this conceit constantly with the ethos of this writer and many like him. There's a certain disingenuity in quoting 1984, which this book does, as a critique of neoliberalism while completely ignoring the deliberate critique of Stalinism, which is found in 1984. There is selective recall when focusing on the body and mental panopticon of neoliberalism regimes while ignoring the relative same strategy of communist regimes. The apologetics in books like this are in the omission of that. The problem with this book, and a lot of the conclusions of this book, is they're pretty obvious to anyone who gives a single critical thought to neoliberalism. Someone with no clue of any of these concepts that the author makes up knows there's something deeply wrong with the system when corporations get bailouts and debt forgiveness and citizens are laden with debt and work paycheck to paycheck. They have no family support. We have contaminated environments and foods, and we have medical bankruptcy and disease and dying, right? You don't need to engage with Marxist dialectics to understand the glaring flaws of neoliberalism. Marxists do not have a monopoly over capitalist critiques, and they think they do. Books like this have no solutions, only cynicism and doom scrolling. I realized, talking about this book, that I bring a lot of my own baggage with books like it, and maybe that's unfair to the book. However, I have no doubt with this author that if I were to push back on his ideas or hypocrisies, I'd be deemed a Western propagandist and dismissed with that, thought-terminating cliche. That's all I have to say about this book, Psychopolitics. It's short. If you're not familiar with critiques of neoliberalism, you can certainly read it. Half of it will make sense. The other half is just jargon. Anyway, that's it. All right, I just want to talk about two fiction reads, because I read fiction all the time. Ubik by Phillip K Dick. I recently read for the first time, which I enjoyed. It was a really I slowly but surely I'm becoming kind of obsessed with Philip K Dick. I've only read Do Androids Dream of Electric Sheep, which I absolutely loved, which I think I mentioned on this podcast. There's a certain quality to his writing that is like dreamlike enough to bring mystery, but tangible enough that it doesn't leave you dissatisfied. Not all writers who write like this can get away with it. You can write in weird, tangential, and meta ways, but the story can't fizzle out into ambiguous, like conclusions. I think Ubik rides that fine line and pulls it off, in my opinion. So, Ubik is a book about, man, it's hard. It's kind of hard to quickly describe. The story revolves around a company who uses telepaths to secretly infiltrate organizations, and it's the same kind of cyberpunk world as Do Androids Dream of Electric Sheep. And the plot is driven by a new type of telepath, a young girl named Pat who can change the past. A main character named Runster leads the group of telepaths with his associate named Joe Chip to thwart another cabal of enemy telepaths on the moon. But then the story takes a really bizarre right-hand turn. And this is going to be a spoiler, okay? So skip ahead if you don't want to hear this. The story turns to Joe Chip, who is trying to figure out what is going on after Runster dies in an explosion. And then time starts regressing, and they all start going back in time. And it's really weird, but it's really engaging. Philip K. Dick does an amazing job with his economical prose and keeping you in the weird, degenerative world that is happening in real time. Joe Chip discovers that this character, Runster, is giving him secret messages, and he suspects that he has half died and is living in a form of cryostasis purgatory, where people who have died live in a new para-reality and can influence each other. And it turns out all of them have been dead half the book, and a young Half-Life kid is playing as this like malignant god to them all. It's another twist in the end when it turns out that Runster is also dead. Anyway, it's just very like, I feel like this book was kind of like where meta was kind of born. Not born, but you know, when this was published, there probably wasn't a lot of like meta-like books like this. And the reason this book worked for me is largely the storytelling. Philip K. Dick has a knack for putting you in the moment, and then the mystery of the plot and its pacing worked really well, and I found the ending to be ambiguous, but not so much that it left me disappointed. I also love the dystopic anarcho-capitalist world here, and all the underlying commentary about God, faith, and reality. It was just cool. It was a cool book. It was interesting. I really enjoyed it. And this book was on Time's 100 best books of the 20th century, which I don't think it's that good. I think that's a bit much, but I enjoyed it. So that's Ubik by Philip K. Dick. And then I just want to mention another fiction read called Lancelot by Giles Kristian, which I really enjoyed. This book had been on my radar for years, and I love Arthurian tales. And I couldn't get this to the top of my TBR until I recently got to it, and it's awesome. It's totally awesome. I wish I'd read it sooner. This is the first book in a series, and it's a first-person POV of Lancelot in the Arthurian myth, and it's full of so much fleshed-out characterization and arcs that it sucked me in to just the last page. I found it's like a coming-of-age book along with a progression of a warrior, Lancelot, who becomes a hero and then a myth. It was amazing watching the progression of Lancelot and how the story turned out. The storytelling was phenomenal. I loved how it ended. I also loved the nod the author makes in acknowledging Cornwell's fabulous The Warlord Chronicles, which is an Arthurian trilogy that's one of my favorite series ever, that you should definitely read if you haven't read it yet. The book started out slow with Lancelot at the age of 8. He's a prince of a kingdom. Some things happen, and then he's rescued by Lady Nimue, and he lives his adolescence and his formative years at her keep. And he obviously discovers Guinevere, I don't know how to say it, Guinevere, the love interest, and then mysticism with Merlin. And he learns the craft of war. He shows his true bravery by compassionately kind of like hospice killing of one of his friends. It's really beautiful scenes. And all that just happens in the first half before Arthur even shows up. And the rest of it doesn't glorify war. It just shows amazing character progression of Lancelot. And it's just a retelling of the Lancelot point of view. And I thought it was awesome. It's a 3-book series. I haven't read the rest of it, but I would highly recommend Lancelot by Giles Kristian. So check it out. So I'll wrap it up today. Thanks for listening. You can email me at icudrecmo at gmail.com. icudrecmo, ECMO at gmail.com. If you have any questions or emails if you want me to make a podcast about something, give me some suggestions. If you send me an email, I reserve the right to read portions of your email anonymously on the podcast unless you tell me otherwise. I will not. Please rate and review the podcast on Apple and Spotify and wherever else you listen to it to help the podcast grow. And please share it. And that's it. Thanks again.